Good afternoon, everyone. Thank you for joining us. We'll just give it a few minutes or a minute before we start, just while we get everyone connected. All right, everybody's starting to connect now. So good afternoon, everyone. My name is Liz Deepers, and I'm your ARACY webinar host today. Before we begin, I'd like to acknowledge that we live and work on lands whose sovereignty was never ceded, and acknowledge the deep connection Aboriginal and Torres Strait Islander peoples have to country and community throughout Australia. We pay respects to elders past, present, and those yet to be. ARACY supports the Uluru Statement from the Heart, and we seek to see children thrive. Children are central to the Uluru Statement, and through meaningful dialogue, change can be driven to build a better future, and we are open to change. Responsive relationships built through dialogue and positive interactions are crucial to developing healthy brains and healthy lives. We acknowledge a history of displacement can have intergenerational effects, contributing to adverse experiences for children and families. Through supporting and modelling respectful dialogue in the community, we'll promote connection and engagement to deliver improved outcomes for children and families. ARACY hosts webinars to share information and promote discussion across a range of topics. We welcome the opportunity to highlight the research of others and centre the voices of those with lived experience. Through our webinars, we seek to grow capability and knowledge across the sector. During today's webinar, your mics and cameras will remain off. You'll be able to add questions for our panellists via the Q&A function in the control panel at the top of the Teams webinar window. Please post questions at any time. We'll be having a discussion and answering any questions after the presentation. This webinar is being recorded and will be made available on the ARACY website and YouTube channel. We're really pleased that you could join us for the first in our 2024 series of lunchtime webinars that will showcase the work of the Longitudinal Studies Collaborative. And it's my pleasure to introduce to you our MC for today's event, Professor Jo Bowden. Professor Jo Bowden is the former director and current principal scientist of the Christchurch Health and Development Study, having worked on the study for almost 20 years. Originally trained as an experimental social psychologist, Jo was a member of the expert panel on cannabis, led by the New Zealand Prime Minister's Chief Science Advisor. His research interests include mental health and substance use epidemiology, and the psychological and psychosocial determinants of maladaptive behaviour and substance abuse. Welcome, Jo.
Thank you very much, Liz. Australia and New Zealand are among the few regions in the world in which the use of illicit substances remains within the top 10 causes of disease burden. The ability to study each substance class has been limited by their low population prevalence in single population-based cohort studies. The Monitoring Illicit Substance Use MISUse Consortium was established to address this problem by bringing together 4 mature prospective cohort studies across Australia and New Zealand. And it's at this point I'd like to introduce our speaker today, Dr. Christopher Greenwood. He's an early career research fellow at Deakin University and principal investigator of the Monitoring Illicit Substance Use MISUse Consortium. He is the lead data manager and analyst with the Australian Temperament Project and co-leads the data science stream in the SEED Lifespan Strategic Research Center. His research field includes life course epidemiology, addictive behaviors, including substance use and gambling, and longitudinal analytic techniques. Chris will present on the early developments of the MISUse Consortium and the challenges and strengths of working with cross-cohort data. He will also examine current research efforts and future directions intended for this project. So I'd like to hand over to my colleague, Chris, for the presentation.
Thanks, Joe. I'm just going to share my screen. Thumbs up if you can see it, Joe. Yep, great. Okay. Hi, and welcome everyone. And thanks, Joe, for the introduction. Thanks for inviting me along today. So as Joe said, my name's Chris, and today I'm going to be talking about the Monitoring Illicit Substance Use Consortium, or the MISUse Consortium for short, which is a body of work that's been under development for a little while now, and that's trying to make use of several of the cohort studies that we have across Australia and New Zealand. Just as a little FYI, before I kind of get into it, this MISUse Consortium work is only just coming out of a developmental period. So much of this talk is actually going to be framed about, why this project is needed and important, where it could go, rather than focusing on any kind of, specific findings from this work. Before I get into it, I would also like to kind of briefly acknowledge some of the past consortium work that many of the cohorts that we have included in this current project have also been involved in. These previous consortiums have really paved the way, made my work much easier. Two key examples that I want to mention are the Cannabis Cohorts Research Consortium, which was a little bit before my time, but had a particular focus on examining high-frequency cannabis use behaviours, and also the Intergenerational Cohort Consortium, which I've been more closely involved in, which is focused on maximising the use of kind of rare intergenerational data sets. So just, I want to acknowledge that this current work has come off the back of a lot of prior work as well. Just as a very quick outline, I'll give a quick introduction about myself so you know who I am. I know Joe touched on a few of it, so a bit of that stuff there. And then I'll give a bit of time talking about the background, why illicit substance use is still an important topic, particularly in our global region. And then I'll talk about the MISUse Consortium, some of the, how it's been developed, and some of the initial directions of the project and where it can go. Right, so I've worked at Deakin University in Victoria since 2015, and I primarily worked with the Australian Temperament Project that Professor Craig Olsen is director of. So if you don't know much about the ATP, it's one of Australia's longest running cohort studies, and it's been running since 1983. We currently have that study has 16 waves of data collected, soon to be 17 this year, and a whole next generation component of the offspring as well. So it's a big study. My role with the ATP has been spread across data management and data analysis, and then I also did my PhD using data from the ATP, looking at longitudinal substance use behavior, which finished in 2021, so kind of still semi-recently. As Joe said, I'm also co-lead the data science stream within Seed Lifespan. And as of this month, I've also started my Alfred Deakin Research Fellowship. So an exciting 2 years ahead where this project is going to be the focus. So if you can't, I'm kind of hoping it to be clear that I've got an interest in analytic methods, particularly those with longitudinal cohort data, but most of this talk is going to try to stay away from the stats. One last thing is that I'm going to use the term illicit substance use. And when I say illicit substance use, I mean drugs like cannabis, amphetamines, cocaine, ecstasy, opioids, kind of the classics, I guess. Other terms in the literature can be things like hard drugs or narcotics, or even just the term drug use. Like this project, I won't be focusing on other substance use behaviors, which are technically illicit, the non-prescribed use of prescription drugs or underage drinking. They're both important problems, but have been limited from this current thing. And I also want to acknowledge that, the term illicit is by definition, it's a bit problematic. What is defined as illegal changes over time. We see differences in the definition of illicit across global regions and in terms of the changing medical use. In our region of the world, and from when these data that I'm going to use came from, a lot of this drug use was still considered illicit, but this would likely change going forward, particularly in terms of cannabis. We see big changes in that. The other good thing about the term illicit is that it gives me a catchy acronym for the project. So I'm sticking with that for now. Okay. As for the background, to limit things, I'm going to focus on data from the global burden of disease work. So if you don't know much about the GBD, the Global Burden of Disease study provides a comprehensive picture of mortality and disability across countries, time, age, and sex, and it quantifies health loss from hundreds of diseases, injuries, and risk factors so that health systems can be improved and disparities eliminated. Right? I just grabbed that text from one of the GBD websites. And so substance use comes into the GBD as one of these risk factors that contributes to the overall disease burden. So to start with, I've kind of got like a good point for illicit substance use. Globally, the overall impact of illicit substance use on the burden of disease is low in comparison to both alcohol and tobacco, right? Like the numbers that you can see in that green box for drug use down the bottom is the smallest number. So that's a good news story. But over the past 30-odd years, the impact that illicit substance use has had on disease burden has increased most notably for this drug, right? So you can see in the red box, there's been decreases of tobacco use across the last few decades, but alcohol and drug use have had an increased impact, drug use the most increased back. So even though the overall impact of illicit substance use might be low on GBD, the proportionate impact of illicit substance use has been increasing rapidly in recent years. When we look globally at who illicit substance use is impacting the most, one of the groups of people are young people. Out of all the age bands that the GBD work has examined, it's the people in the adolescent and young adult age range that are experiencing the most disease burden from illicit substance use. As a comparison, drug use is considered as the 6th most leading risk factor for young people aged 10 to 24 years. But overall in the population, drug use doesn't make it into the top 10. Also, there we go, got it. Also, what you can see in this red box here is that drug use has remained in the top 10 risk factors for young people aged 10 to 24 since 1990. So this has remained as a persistent risk for these young people. When we then start to look across the global regions of the world, we find that Australasia, which is primarily Australia and New Zealand and some other islands, Australasia seems to be at particularly high risk for disease burden from illicit substance use. So for instance, of the 21 global regions that the GBD work looks at, Australasia is one of 3 regions where illicit drug use remains in the top 10 risk factors for GBD. And also it is one of only 2 global regions where this risk factor has increased over the past decade. So illicit drug use has remained remains an important risk factor for GBD in Australasia specifically. So we can drill down a little bit further next, and we can use some of the population representative cross-sectional survey data that is collected across Australia and New Zealand to see the extent to which patterns of drug use spread across the population. Right, in this slide you can see here, I've just focused on the ages of adolescence and young adulthood, which is where much of the initiation, experimentation, and maintenance of substance use behaviours occurs, and where the GBD data also suggests that disease burden is most impacted. So in this table specifically, what the numbers presented here are the prevalence of past year use. So that's any use in the previous year from whenever these kind of recent-ish surveys were administered. And what we can see is a classic developmental pattern of use increasing from adolescence across the transition into young adulthood. The main take-home point here that I'd like to make is that we do see, quite low prevalence of some of these behaviors, particularly in adolescence. Like some of the ecstasy, amphetamines, cocaine, adolescents in both samples are relatively low prevalence. And even some of these drugs that they transition into young adulthood, we still see low prevalence. And this is just at the past year level of use. If we were to then try to examine more regular, more problematic, more frequent patterns of substance use, these prevalences would obviously be even further smaller, right? Now, this is obviously a good thing in many ways. Low prevalence of a harmful behavior, that's good. But from an analytical perspective, the researcher who has to make use of the data, it does cause some difficulties at that end. Right. So as I was kind of saying, that the problem that other researchers will face when we have these data is that despite knowing that illicit substance use is clearly an impactful problem, the low prevalence of these behaviors makes the statistical work quite difficult at times. This can be exacerbated in certain populations, like in non-risk populations where patterns of substance use are low, like in general population samples. And so what we see here is there seems to be a lot of researchers that focuses on using risk populations, like incarcerated individuals or boys with behavioral problems, that sort of thing. We also say this low prevalence issue exacerbated in longitudinal studies where it's the most vulnerable people, the most at risk, those who are going to use substances, that actually are going to attrit from these cohort studies. So this will further exacerbate and create our low population prevalences. And then the last kind of point I want to make here is in terms of how the low prevalence of each of these behaviors means that a lot of research has to clump drugs together, just any drug use across all types. Now, that's probably suitable in many cases, but it does mean that past research is not able to well differentiate across substance types. Great. Okay, so now that brings us to actually talking about the MISUse Consortium. So as other consortium have shown, like the CCRC and the ICC that I mentioned at the start, one way to kind of get around this analytic issue of the low prevalence behaviors is to increase your sample size. In our case, where we have already collected cohort studies, we can't go and collect new people per se, but this can be done by combining several cohort studies into one study. And by combining, I literally mean taking dataset 1, dataset 2, and putting them into one big dataset. In the case of MISUse here, when we combine our cohort studies, what we get is we get more absolute cases of people endorsing a particular behavior. The prevalence will stay low, but we get more cases reporting substance use at a certain level. And it's this absolute, it's the increase in the absolute number of people reporting a behavior that allows us to build better analytic models and answer more questions with more certainty. So as a brief overview, the MISUse Consortium currently includes 4 cohort studies. That is the Christchurch Health and Development Study that Joe's worked very closely with for, I think, 20 years, he said. The Australian Temperament Project that I've worked on since 2015 and Craig Olsen is director of. The Victorian Adolescent Health Cohort Study, Craig Olsen again, and the International Youth Development Study, which I don't know if John's on the line, but I go to John with my questions about this study. So these cohorts have been variously established across the late 70s to early 2000s and together have over 8,000 participants. They've collected between 10 and 24 waves of data collection, and all in all, we have a lot of data here, right? It's a lot of data to make use of. Now, sorry, it's a bit cluttered slide. This is meant to be one image, but I've split it up into 2 to try to fix it, to try and fit it on. But one of the first things we've done with the MISUse Consortium is try to map the substance use assessments across the studies and ages. So the 6 most consistently measured substance use across each of the cohorts, as I've kind of shown in the red boxes, are cannabis, amphetamines, cocaine, ecstasy, hallucinogens, and opioids. Now, what each of the markers represent on the picture is a time point in which each study has included an assessment of that drug group type, right? And these green boxes are approximate developmental periods. And what we can see is that there is a varied number of assessments across the studies within each of those developmental periods. What this means is that we're going to have to make decisions about how we collapse several measurements. So like we're probably going to have to create things like adolescent cannabis use, young adult amphetamine use, those sort of things. Now, what's not shown in this figure is how the item wording varies across cohorts and across waves within certain cohorts. And by item wording, I mean things like some studies asking about how much did you use in the past year, other studies asking how much did you use in the past month, and then also about whether questions ask how many times have you used versus how many days. So I'm not going to get into the weeds of how all these decisions kind of come together, but it's just good to be aware that when we're working in this consortium space, we are making decisions, we are making assumptions about how these data can be combined to be used eventually, right? So it's a bit of give and take. So with all that being said about the assumptions, I'm jumping straight into something that I'm presenting. I've made all the assumptions behind the scenes, and what here is showing is the harmonization approach capturing monthly substance use of each type. So the numbers on each of the graph here show the number of people endorsing the behavior, so that absolute number, but then also the proportion of the sample endorsing that level of the behavior as well. What you can see here, besides cannabis really, the prevalence of monthly use is very low in many cases, particularly in adolescents. But what you can also see is that even in some of the cases with low prevalence, we are starting to capture an absolute number of participants which might be usable in some of our analyses. So I've just picked one out here, and here you can see this is adolescent monthly hallucinogen use. And while this is at 1.5% of the combined harmonized sample, we're still capturing about 60 participants who endorse this behavior. And so this gives us something that may be a bit more usable down the track for our analyses. Right, and so I don't want to focus here, and I don't spend time trying to figure out what's going on here. But obviously, to do work in this space, we need more data than just the illicit substance use data. And this slide here is just very high level show that each of these cohorts do assess a range of other constructs across a range of developmental periods, and there is a high level of degree of possibility for harmonization. So this is just kind of like a heads up. We know we're going to have to use the data to look at antecedents, consequences, and that data is there and will be available, sorry. Right, so in summary, the MISUse Consortium is, it's a really large data resource, I feel. We've got four cohorts, over 8,000 participants, 6 key illicit substances across adolescence, young adulthood, and into adulthood, and a range of antecedent and consequent data that I just popped on the screen before in the previous slide, right? And now what next? So we've kind of got to this point, what next? We've started this project very much from an investigator-driven basis, and by this I mean our initial research questions are those posed by our collaborators on the project. It's a big team in this consortium, and we have a diverse array of collaborators. We have representatives from each of the included cohort studies. We have clinical researchers and those with clinical expertise, and then we also have those some people with experience in government policy. So we do feel that we have a good starting point for developing some of our key research questions, but ideally, over time, I would love for this project to develop into something where we can make use of participant groups, stakeholder groups, lived experience to help define and refine some of our research questions that would be particularly relevant to the studies, to the people that the studies are about. So that's kind of where we've got to, right? And to finish off, I'm gonna very briefly touch on some preliminary findings, not what they mean, but kind of showing how this consortium approach can strengthen our conclusions. Just to finish off in the last minute or so. Right, so look, I know this is a bit of a cluttered slide, but I think the point that I'm trying to make is consistent across these slides. So starting on the two graphs on the left, what these plots are showing is a representation of the relationship between amphetamine and mental health problems and vice versa. And what the graphs on the left are presenting is a risk ratio. So it's a comparison of risk between two groups. They also have the confidence intervals. Now, if you don't stress about what these confidence intervals mean if you don't know, but essentially tighter confidence intervals help us as researchers to make clearer and more precise conclusions from our data. Right, so more specifically here, this top graph is looking at adolescent amphetamine use and young adult mental health problems, and then the bottom graph is looking at the reverse, adolescent mental health problems and young adult amphetamine use. And let's get this to pop up. There we go. And what you can see here is that in the harmonized sample, so that's our combined, 8,000-ish, we have much tighter confidence intervals on our risk ratio estimates. So after all this work, this is kind of where we get to a slightly tighter estimate. We have the same thing on the right as well. Obviously, it's a bit of a cluttered graph going on, but this is some early work looking at the natural history of these behaviors. And it's the bold line that hopefully you can make out that has again, it has tighter confidence intervals, so more precise estimates than any of the kind of colored blurred outlines in the background. Right, so anyway, not meant to be interpreting here. This is just kind of, after all this work, we end up with an ability to make more precise interpretations from our findings. That brings it to the end. I think I've just gone a tiny bit over, sorry. But I hope this presentation's kind of shed some light into the early stages of this work. If you're interested in knowing more, obviously reach out. And I'd like to say thanks to everyone, that's helped support me to get there, and particularly a huge thanks to Craig Olsen for his support of me personally, but this project as a whole. Just some references. Yeah, and that's the end. Thanks.
Thank you, Chris. And I just wanted to say on behalf of CHDS and myself, it's really great to work with you and to be part of this project, carrying on in many ways from the tradition of the Cannabis Cohort Research Consortium, which looked at some really important aspects of cannabis-related harm that were just too difficult to do in the context of any of our individual longitudinal studies. I would just like to remind anyone who's in the audience that if you do have a question, if you could add that to the Q&A channel, so I can forward that on to Chris. It says new posts. Yep. And just signifying, please feel free to post any questions for Chris below. But I can sort of get started with a couple of questions.
Yeah, I think Craig's, I don't know if Craig's also sent one through in a chat, but I've got something pop up as well. So yeah, don't know if that's popped up.
Oh yes, so yeah, Craig's he said, well, I will read the compliment as well. Fantastic work, Chris. Such an important initiative around such important topic. What is the future scope for bringing on additional cohort studies into this work from our region?
Yeah, it's a great question. I'm so keen for this to grow. We've currently had some kind of casual conversations with the RAIN study, which I think is WA. I think it's pronounced MADUP in New South Wales. It would be great to also get the Dunedin study involved eventually. So I'm totally keen to have this involved. Part of the part of the difficulty has been the agreements that have to go part with this, right? The legal stuff, all the stuff that happens, and that can be timely. So I'm super keen for this to grow, and I'm aware of the kind of work that comes with that. It would be great eventually as well to kind of branch out into some of our non-Australasian cohorts. Like Craig always kind of talks about this. We've got some connections with the Netherlands, in the UK as well. And I think Craig was mentioning, I think it was Singapore recently, or I might have been getting it wrong, but I'm very keen for this to grow. Like, first off, I think I'm keen to build Australasia nicely, but then, yeah, the more the merrier in here, right? Bigger the end, the better.
Indeed. Now that you've been working with the data for some period of time, and he's had ours for at least a year, what do you think what are your thoughts around how we could possibly achieve greater or better data harmonization in the future?
Yeah, I think about it a lot, and I think one of the, I've got two thoughts. Some sort of data federated sharing platform, I feel like will one day be the way of the future, where, institutes, cohorts are not giving up ownership of their data, but those data are accessible via some sort of cloud infrastructure, right? One day I imagine it going to like a thing like that. We're, for another project, we're working with these collaborators from Europe, and they're just not even allowed to share data out at the moment. Like the whole EU has a data lockdown. So there's definitely going to be movement. I would also like to kind of comment on, just link to the MCRI life course stream as well, like a kind of another cross cohort thing. They've put together some, they're working towards providing resources for how alignment across constructs, but I think that's early days there as well. But I think a lot of this work, will come in the future, and I'm very keen to see where it goes.
I think one of the things that I love most about science is this idea of large teams working together on significant problems, and I really feel like this is one of those areas in which we really actually could make a lot of gains by banding together, which is why I'm so excited to be part of it.
Yeah, big time, big time. Yeah. I think
Delise says something in the chat. Terrific project, Chris. So great to see the work of the CCRC and ICC extended into this new focus. Can you tell us a little more about some of the research questions you are hoping to address that might inform policy and/or practice?
Yeah, thanks, Delise. It is great to see this project extending on that previous work. So some of those graphs that I had at the end were kind of two, like I'll focus on the mental health amphetamine use. That question actually probably inspired this project even before my time. Like I think, Joe, that was maybe you and Craig thinking, oh, amphetamine, like I can't even remember, but it was before my time. And I think that really inspired the project. I would love for it to develop into something where we with a harm minimization focus, where I can look at why do some people experience more harm than others when they're using drugs in the same way? Like, why is it someone who's a amphetamine user monthly and another amphetamine user monthly, and they have completely different outcomes? I would love to get to that kind of point. I think I've done a tiny little bit of that work with ATP specifically, and around like social skills as one of those moderating factors, but I would love for it to go into that harm minimization space, like how can we help, or what leads to more risk versus the opposite. Yeah, I'd love to get there.
That's great. I've got a really left field question for you. And that is, if you could add any type of data, now that you know what data you have available to you, and what if you could add, if you had a magic wand and could add any sort of data to that data set, what would it be?
It's linked data. Like I would love to get hospital linked data. They've all got their benefits. Like hospitals or linked data would only be getting the upper end of problems, right? But with linked data, we would be able to find out those highest risk people that drop out of cohort studies that may be using drugs. If they're at that upper end, and coming through those systems, that's where we'll be able to recapture some of that. So without a doubt, it would be linked data broadly, whether it's hospital, medical, that sort of thing. Yeah, 100%. If it gets there, that'd be amazing. We've always had trouble with linking data, but it's great to have a goal.
Indeed. What we've found recently too, we've had a partnership with the GIS laboratory at the University of Canterbury, for example, or adding environmental data to the CHDS database. And we were a little skeptical at first, but the returns are starting to look like they might be quite significant. So those are even to other things like such as that are the sort of things too that I think that as social researchers we didn't have the tools for,
Exactly.
but nowadays we're getting much better tools.
Yeah, yeah. I think there has been a little bit of work in ATP, and I think the VAC study as well. It's probably in the intergenerational, the next generation stuff, but we have done a bit of geocoding in terms of like some of those pollution, green space things for someone else's study. So yeah, that sounds great. Yeah, I love any of that kind of like high level epi bits. Like I love to bring that into these things. Yeah, real compliment.
I just wanted to ask that if anyone in the audience has any questions, you're just about out of time to ask them.
Get in quick.
Let me just see. So we talked a little bit about data access. So how do you see, in terms of the project going forward, how do you see the data from the project being put to best use in terms of informing stakeholders, researchers, clinicians? What's the envisioned pathway for all of that?
Yeah, it's a tricky spot for me at the moment. It's one of these kind of like a sticking point, right? So like as I said, I want this project to grow. I don't want this to be something that only I can do. I want the team to be able to lead these kind of aspects as well. The first thing that I have in mind is reworking on these agreements that I have set up, right? To get this to where it has been, it's been very much a me-centric thing. Chris can get the data, and these processes have been quite tricky. But I think, hopefully across this next 2-year period, I can build something a bit more collaborative that allows these data sharing to happen more easily. I know we've got lots of clinical experience in the team, and that is far from my experience. So the better we can get these data into the hands of the people that, can make those decisions, ask those right questions, the better the project will grow, the more it'll be able to contribute. So in my mind, I'm semi-working on it in the background, but it's just one of those sticking points for me, getting these agreements over the line. I think in recent years, it's not all institutes, but just things have become more secure in a good way, making some things a little bit more difficult as well. But no, you'll get there, just time.
Indeed, and please let me reiterate, it's been wonderful having you in this role, and to get this up and moving again, it takes an absolute tremendous amount of effort to be able to do this kind of work, and I think it's fantastic that we've got Chris in this role and doing such a great job. So once again, I'd like to thank you, Chris, for your presentation today, and I'd like to thank Liz and everyone at ARACY for putting this on for us and being great hosts for this presentation.
Thank you very much, Chris and Joe, for sharing your time and your expertise with us today. I'd like to thank you, our audience, for joining us. And as I said at the beginning of the webinar, this is our first in the series for 2024 that will showcase the findings from cross-cohort initiatives that bring together longitudinal studies from across Australia and New Zealand to address questions that can't be answered in individual studies alone. Our next Longitudinal Studies Collaborative webinar will be taking place in June, and we'll be looking at the Intergenerational Cohort Consortium, and we hope that you'll join us for that one and for our other webinars that are coming up. The recording of today's session will be available in the coming week on ARACY's website and YouTube channel, and you can have links shared to that in our ARACY newsletter, which I've just shared in the chat, how to subscribe to our newsletter. If you aren't already, please do. You'll be kept up to date with news, other events like future webinars. We'll now bring this webinar to a close, and we look forward to seeing you at our next webinar. Thanks for joining us today.